I'm Bonnie Bissonette, the Director of Education Abroad and International Safety at UMB, and it gives me great pleasure to welcome two colleagues from the African continent, both of whom have served in their respective countries as ministers of health. And I won't provide a detailed introduction from they both supersede that, but their bios are available on the main conference or summit homepage, not the page with the lobby for our beautiful virtual conference center, but the page where we logged in with all the beautiful blue and the photos. Up at the top bar, there is a link to speakers, and I can urge you to look there to find out the full details of the rich and long careers of Drs. Agnes Binagwaho, welcome, Dr. Binagwaho, who served as the Minister of Health in Rwanda. Pleasure to have you with us, thank you. And Dr. Samba Sow, who served as the Minister of Health in Mali and is also on the faculty at the University of Maryland. Dr. Sow, welcome. I'd like to, before we get started, also make a quick note that Dr. Binagwaho also is serving with the Consortium of Universities for Global Health and spearheading their decolonization efforts. So we are delighted to have two such talented and experienced professionals here to share with us from two different countries in Africa their thoughts on the topic at hand, decolonization. We originally shared questions with both of our presenters today, and in speaking with Dr. Sow earlier, he's prepared some remarks that will address the bulk of the questions. And Dr. Binagwaho, I'd like to start with you with the opening question, and we'll begin a bit of a dialogue. I think I'll be nodding and smiling a lot, but the questions, I will share them with you now as an audience, so you'll know what the questions are that they'll be discussing, but I look to sort of sit back and enjoy the dialogue. The questions, and the first question I would address to you, Dr. Binagwaho, to start with would be, as two former ministers of health in countries that experienced colonialism and independence movements, what does it mean to and for you when we speak of decolonizing global health? And we'll get to the rest of the questions which flow from there. Thank you.
Okay, thank you so much, first of all, to having me. Thank you, Carlos. Thank you, Bonnie. Thank you, all the students and all the people who have helped you to set this great gathering together. So decolonizing global health means a lot of things, because I have to tell you, the colonialism and the what we call Western supremacy, white supremacy, high country income supremacy is embedded in everything that we are all swallow from the first drop of milk that we receive. So it means bridge the gap between theory and practice by creating a real framework to shift the center of gravity for what we call the global south, but the low-income countries that most of the time map really the former colony, to shift the center of their gravity of global health inside their country. It means also that we need to change people's attitude regarding the value of what the global south can bring to the table, about also providing resources. There was a great article recently in the Nature saying, how did you give to an American the NGO the money to do research about malaria in Africa? We have enough researchers. Give them the opportunity not to be treated like second zone researchers. So, and I also want that the delay we have. I totally understand about the reparation about slavery in the US, but we have to understand also that the lack of progress we have can be explained by the fact that since 1960, the rich countries have taken out of Africa $172 trillion through extracting our good, etc., in our soul without that bringing back resources to us and not allowing us to develop our people for education, for health, for infrastructure, for construction. And it has continued to build the rich countries and to make us poorer and poorer. And also, when you fund institution, you need to fund the South for studies to be done by the South. We can partner, it's okay, but not lead like people who have a brainless. And so partnership is great, solidarity is great. And I can give you also an example, not only in money to build, in money for research, in the way we publish what we have researched. There is article for COVID done by US people, US based, talking about what happened in Africa. They were accepted in a high, very known scientific paper. The paper done by African, talking about Africa, living in Africa, well written, was refused. And also you can see that the world, the entire world, was watching more the non-African based article than the African-based people article. So the readers are biased, the journal are biased, the finance, the financial source, those who are decided are biased. We are all biased. So it means a lot.
Wow. Yes, thank you. And I appreciate your candor and speaking very straightforward as to the degree of the effect that colonization has had and continues to have. Dr. Sow, are you with us?
Yes. Yes, I am with you.
Please, if you could respond to the question, and I know you'd like to continue. Do you mind? I'll just share some of the other questions you'll be addressing as we go through.
Yes, please.
The other questions we asked both Drs. Binagwaho and Dr. Sow to address would be, what would you like to share with the 90+ students and scholars that are participating in this summit in terms of how they can have an impact in health equity in their future careers? And of course, I'll remind everyone that we're talking about students from multiple professions that are joining us here today. Social work, dentistry, pharmacy, medicine, nursing, law, and students that are getting doctoral degrees in any number of those degree areas. We also asked about how the decolonial lens and movement can best improve global health. And in addition, in a world in which we dismantle unequal power structures in the field of global health, what is the aspirational goal of the field? We also asked about whether COVID-19 pandemic has facilitated a conversation about decolonization. And I don't know, the two of you may not have seen, but we had the statistics shared with us at the beginning of the summit yesterday, in which we learned that 98.8% of the vaccines for COVID-19 have gone to mid and high income countries, 0.2 to the lower income countries. And I think that speaks directly to this. Dr. Sow, please, thank you.
Thank you very much, Bonnie, and thank you very much, Madam Minister Agnes. Great point, bonjour, and so pleased to see you again. Still with the same very strong, robust African energy. I need that. Thank you very much for your points. Very well taken. I mean, learning from what you said and hearing from what you just shared with us, I completely agree with you. And I just would like to build on top of that and say, try to gather these questions, because to me, they are all linked. Great questions, Bonnie, really absolutely great questions. Before I start that, I just would like to thank the organizer of this summit. UMB Global Health is really up and running. I've said this to President Spearman and to the Dean Alvarez. I told them that this is the way to go forward, and it looks like it's really working very well. We would like to see at the end of this meeting what will be the main point to share. So living with responding to COVID, I know COVID is one of your last question, but I really think that COVID is, the way COVID is today, we cannot do anything but talking about that. So responding to COVID-19 over the last year or so has shown us clearly, I think, that the only way to address the complex issue facing us today is to collaborate. So that's the number one keyword that I want to put there. We need strong partnership, very strong partnership, strong international cooperation, and crucially, we need equity to be at the forefront of this issue. That means that we need inclusion, as it was said by Minister Agnes. There cannot be equitable partnership without proper and considered inclusion. That's very important. And without proper country presentation, without the proper partners being invited to the table, I think it is very hard to talk about country ownership and decolonization in any meaningful sense. That is to say that when faced with the many challenges and the great many difficulties of the moment, COVID-19, of course, and ongoing structural primary healthcare issues that face countries like the sub-Saharan African countries, especially like my own country, Mali. We have COVID pandemic, and we also have political upheaval pandemics. We have political crisis, security crisis, coups and counter coups like every hour. We can actually go a long way to answering the broad general questions of colonial legacy with concrete steps here and now. This is all part of a big package. And inclusion is key in that, has its proper representation. When we try to think of solutions to problems such as we face today, one important step toward decolonizing attitudes and actions is to make sure that decisions are taken and implemented in the most suitable places. This means giving credence, space, and trust to institutions and partners who know the countries and territories in which they work. This has been clearly said by Minister Agnes. So local and national government won't always know what is right, of course, but never never will funders also know about that. If, however, we make sure that invite the right people to the discussions and listen to their opinion, I think we have a better chance of arriving at a solution which are not imposed from outside. And that was clearly described also earlier by Minister Agnes, for the benefit of outside partners only, but rather are conceived and implemented close to the communities we seek to serve. I've learned over my career that it is communication that is key. Communication is key. Having platforms like this, congratulations to you guys for arranging such a great summit that will allow us to share, to communicate, to discuss. listen to your communities, listen to your partners, and listening to what countries need and want is key. I have spent most of my careers translating evidence for policymakers. There are a lot of publications around that, or translating science for communities. We call this data to action. This has been on and on. We published a lot around this. This only works when all parties come to the table with equal say and equal influences. That is the only way we will get most evidence-based and efficient intervention into our communities where they can have the most impact. My opinion on colonial questions are closely linked to my opinions as a scientist, and many of the frustrations I have felt over the years come from that. For example, it can be frustrating to see actions implemented and driven by external forces from when you know as a scientist that those activities, evidence-based for communities, they are being implemented. So we try to act on that basis of available evidence. That is the concern of our work as scientists. And we try to remove bias from our trials and experiments as far as we possibly can. I think then that we can adopt a similar attitude to questions of coloniality and decolonizations. So quite simply, we should try to apply our bias reducing principles wherever and wherever we can, whenever we can, wherever and whenever we can. I mean, this means insisting on a variety of voices. It means listening to people who have experience of scientific fields and of literal fields, that is their own countries and communities. So I just want to say about one of your key questions on how knowledge, this is my last point to mention. This is one of your really key questions, how knowledge that is mostly made in the global north fails to address the real needs in the global south. Would you give us an example, that's still your question, of how this state of affairs challenges effort to meet health needs in your respective countries? So I will just say very quickly that this speaks to the fact that the agenda is often set and driven by the global north rather than countries themselves, and indeed the communities where the needs and questions arise. So good equitable partnership, again, good equitable partnerships are the foundation. We need to ensure we can answer the complex health issues, develop the product, and address the emerging health problems we are seeing around us. I am very lucky that I have many of those great partnerships and proud of what we have accomplished together. One of these great examples is my great partnership with the University of Maryland, CVD Global Health, the whole university. My American partnership, currently great opportunities for myself. I would like to congratulate again, even by inviting me to such a great summit. To me, means a lot. It's part of a decolonization of this whole thing. So you are ahead of time. You are very proactive. This is leadership. Your university leaders are ahead of time, very proactive, good action. But I also have sadly seen to many instances where money, as this was described so nicely by Minister Agnes, money and time is invested in the wrong way or to answer the wrong question that we don't need necessarily. So it will only work if there is a strong, equitable partnerships and good communication. Thank you.
Thank you, Dr. Sow. Dr. Binagwaho, would you like to react?
Was on mute. My reaction is yes, yes, yes. And we have a lot of example around that. If we go for your question about creating a global model, the high-income country push of the brain drain. You had a question like that? Oh, I did change your question.
Oh, you could answer whatever question you feel is important to get the...
Yes, I got it, Bunny. I just want to say that the way the relations are done and the way the investment is done systematically in high-income countries and in low-income countries, the value of my work, even if I'm a better expert, and I want to challenge all the experts in the high-income country, I'm sure there is no reason to pay my time lower than their time. And this is also a colonialist attitude, because if we do a work for 15 minutes or for 10 minutes and its value $100, is for me, they pay me only 25 or 50. That means 5 minutes I'm working for free. What is called a working for free if it's not slavery? Just tell me that. So they slave me, they slave my brain, they use it, and they underpay me just because I'm coming from the global south. So this is also a colonial that is systematically used, even in the best partnership with US universities. They all agree that our researchers are paid less for their time and their discovery in that great partnership. So even the best, what I'm saying, colonial mindset is so deep embedded since the first drop of milk, breast milk or buttermilk, that we need to change everything. Another thing that we can, and for me, at my University of Global Health Equity, we say no. We say no. Slavery, we are all fighting it. Open your eyes. And the big problem, dear Bonnie, is that many of our best friends in high-income countries are collaborating to this slavery without being conscious of that. The traditional knowledge that is undermined, but so much used, because look all the current working medicine for malaria. You have big pharma in the north that are taking advantage of the great knowledge, traditional knowledge of people around the world, from quinine to artemisinin, etc. What is the payback to this traditional knowledge of people who can even not grow, not research on their product? This is called stealing. When this is not proper. The other thing for your question on how students can participate in this, how can they in the future be better global health fighters, is by reflecting first around all those issues. Take nothing for granted. We need to think that we need to revisit all the framework, the document, the way we practice, because it's wrong. And for them to revisit the world with a biosocial lens, to look at the world with respect and equity. And it's not because, like many people in my country, don't speaking good English. Many speak. I'm not even somebody who speak good English, but you hear me, and language is done to be understood. And I don't care when I make a mistake and people are looking at you and you seem dumb because you don't express yourself in their jargon. So this is also a colonialist attitude. Be listeners, attentive, try to find what the communication is about, and be humble. So as students, be always curious learners, and I encourage you to contribute to global debate like this great debate you are creating. It's not an easy debate because the ball is everywhere, in the Western world, but it's also in our world. We need to stand and stop to be colonized in our mindset and stop accepting it. And this is a long journey where the next generation will be continuing the fight that we have, that have been started before us. And also to go with the idea that don't be compassionate for the vulnerable in the global South if you are not compassionate for the vulnerable in your country. This is fake compassion. If you can let people die, if you can let the Black community be more affected by COVID, more dying by COVID, having less access to vaccine against COVID, without moving for that, don't come in my country and say that you want to save us. Global health is everywhere. It's not in Africa and Asia. Global health is every place we have our 2 feet. And this is very important for the student to understand that they have to start to change the world where they are. This is the best example you can give for the future. And also understand that vulnerable are not only the poor. In a society where homosexuality is a crime, homosexuals are vulnerable people, etc. So the vulnerability is context specific, even though the regulation of partnership should be context specific if we want to really make a difference. And I can go on, Bonnie.
Oui, et peut-être on peut parler en français parce que ça
Je peux parler en français aussi.
C'est un peu moins colonized. Well, it's not really less colonization, and I don't speak very good French.
It is the same. All those are too colonial. I can speak in my language, but we don't have translation. So English or French is too colonial language. We can analyze on peut analyser la façon dont ils ont colonisé, mais n'oublions pas que aujourd'hui, à l'heure où je vous parle, l'or des pays d'Afrique de l'Ouest se trouve à Paris et ils payent pour déposer leur or, pendant que Paris l'use pour faire des prêts et gagner de l'argent là-dessus. Et ceux qui veulent changer ça sont éliminés. So I don't know if you get what I mean. Colonial is still ongoing and very active.
Yes.
And in Francophone countries, African Francophone countries, what is a nonsense to say like to say that like the France has an ownership in a portion of Africa. However, all the gold of those countries are seated in Paris, and they all pay for the gold to stay there when France rent it and get money out of it. And all those who say we want our gold home are in big, big trouble. So colonial is everywhere. En français, en anglais, and even in Spanish and Portuguese.
Thank you so much. I am blown away by your willingness to speak very, very passionately. And I thank you, because I think that the students and scholars who are hearing your words, who are younger than I, will go out into the world with more information than I know I had at the beginning of my career. And I appreciate very much the passion of your words. I'm going to put you both on the point here now for us. As a university positioned in a high-income country, doing global work with you as partners, and Dr. Sow, I know you know what UMB does, how we do it. We're looking to examine it and take it forward in a positive direction. So what would you tell us? What are some concrete suggestions that you have, knowing what you know about UMB now? What are some things that we should be doing to put this decolonial lens on those things? Dr. Sow, let's start with you.
Thank you. Sorry, always learning, muting and unmuting. I am sorry. Yeah, I completely agree with you, Minister Agnes, Prof.
Please call me Agnes, my dear brother. Call me Agnes.
Samba.
Because in
Call me
Rwanda,
Samba, my dear sister. Yeah, merci beaucoup.
Yes.
Donc, I completely agree with what you said, and I think that Bonnie, what I really think that could be a strong takeaway, not only for the student, but for all of us, including the university. As I said, a few years ago, maybe 2 or 3 before COVID, there was actually maybe your first Global Summit meeting, or if it's not the first, the second. I was invited as a guest speaker. I told this to President Spearman. He was president then. I think now he's even tough.
He's the chancellor of the entire University of Maryland.
Oh my God, I don't know how to call him now. So tell him and tell the current president and the dean that I am saying, as an African technician, as a field worker, as a person who suffered, born and grew up in colonialism, and now trying to help and contribute how to change things in a much more positive way, that your university is being very proactive on this. Even by letting us, my sister Agnes and myself, inviting us in a much more transparent, open way, and let us talk to your students. And I'm sure this group of students are not all 100% Americans. I'm sure there are people from Africa, from Asia, from all over the world. So this is what I call global health. This is what I call a sharing partnership. This is what I call transparency. This is what I call dialogue. And this is what I call communication. So she said it. She said we need to communicate, and non-stop communication. So the key and the number one thing is to talk about it, to let it out, to share. That's the only way then, point by point, step by step, we can figure out how to solve each of the issues and how to make it more global. Look, COVID vaccine. Some countries have enough for 3 times, twice more the country population, while in places like Africa, the number one top high-risk people, healthcare workers, we even don't have enough to cover the healthcare workers. Look, vaccine and many other drugs are manufacturing. Africa, for example, is representing 16% of the global population, but we have less than 1% manufacturing operation in Africa. I can't get that. And so far in many of our countries, we only have one vaccine. We even don't know if this vaccine is working on a variant, etc. So there are a lot of very, very sad issues happening. Global health at this level is the only way to come together, study it together, understand this together, and share together and convince, data to action, generate our ideas and data, put it together in a very objective, transparent, convincing way, and take that to the country leaders. Wherever they meet, in France, in the US, the president of Rwanda is one of the great leadership today for all of Africa. Congratulations to this man. And we are so proud. University of Maryland today, to me, this is a perfect example. I've been in another meeting with some other universities, perfect examples, global health, population health. That was University of Washington last week, for example. This is the best way. And my last sentence is, I said that I was so proud and lucky to be working with you, but also sad with working with other opportunities. So for me, we will only work if there is a strong, equitable partnership and good communication. So let's try to open this and continue to do this. Congratulations to you, Bonnie, for organizing this. And thank you for having us. And congratulations to the university leaders, all of you, for having us here. Thank you very much.
It's our pleasure, and thank you for sharing your time with us. Dr. Binagwaho, we had a question come in for you after your remarks. I'd like to interject. Someone shared that they hear your powerful argument about taking care of your own as well. And it says, I'm wondering if you believe it would be more appropriate for Americans to stay home and solve their own problems rather than be involved in projects in Nigeria, Mali, and other countries in Africa.
No, that's what not I said. The world is a big village, but don't let your people die and come to save us. That's what I want to say. There is the keeping America in a bubble didn't succeed for you. So don't go there again. You have 5 years of experience, don't continue. However, when I see the people going in the road for George Floyd, then I say they are really caring. You understand?
Yes.
And that's why it was not enough. George Floyd came 60 years too late. That's what I want to say. And I hope I'm well understood. Global mean everybody. And I have a dream, you know, Bunny. There is no human race. Something like that doesn't exist. Bunny, you are not white. You are another color. It's between pink and something. White is something very different. It's something like the panel behind me. Mm-hmm. There is no such existence as a white pigment. So there is no human race. So when we even go and say the black race, the white race, we are scientifically wrong, humanly wrong. In my country, there was, we solved the reconciliation by putting the right word behind the situation. We are human of one race and different color of skins. And this, if we don't think about that, and we don't think like that, we are always going to be the harm, the harm or the tool of colonialist mindset and supremacists. Supremacists exist because they believe they are a superior race. Convince them that there is no race, and their dialogue, their speech will be useless. And what a university can do is just to create partnership with equity, respect, dignity, and true solidarity, with trust and love for the humankind. And this will start by recognizing that there is no such a thing than black race, white race, and that the richest you have or the wellness you live in doesn't make you more intelligent, more respectable, and somebody we need to listen to. And also, don't listen to people because they talk louder, because those people can go on radio and TV and do it. And there are so many people who are voiceless, we are not listened to. Go dig and go and see in community who to listen to really, to have those partnerships that are really good for advancing the agenda of global health, equity, and humanity. But fight the word race. I'm another race than the dogs that I have in my garden. But you and me, we are the same race.
Wow. I don't know, do we need to probably end there. I feel like we're a couple of minutes early, Dr. Binagwaho, but my goodness, thank you so much. Dr. Sow, any closing words? Dr. Sow, excuse me.
Thank you. Call me Samba. I said that. Please call me Samba.
Okay.
That's what I hear. Samba means in my cultural ethnic Fulani ethnic group. Samba means second son. So actually one of the reasons I'm really trying to become doctor and fight against diseases is because my elder brother died from some of his vaccine preventable infections. So
Wow.
Yeah, that's why I'm Samba. I was just accidentally became the first, but I'm actually the second. Having said that, I think I would like to still say that my sister Agnes is absolutely right, and say that we do see seeds. There are seeds of changes, and we are seeing ways out of this. And as I said, I would like to really encourage and ask UMB, the university, and all the partners to continue to build this up. I can see that you even have a global health department as part of the university structure. So make sure you communicate well, you strengthen the partnership, you do that in a much more democratic and transparent, equitable and respectable way with your international partners, and also strengthen the communication and the sharing, and that's the only way, and teach that to the student. Usually we learn that after becoming doctor. So you study medicine, nobody will say something like this to you. It's not part of your exam, so you don't care, you don't read about it. And then when you finish, they send you to work someplace. And then these things will happen to you. And then you'll be, what can I do? What is going on? So teach this. These things, what we said here, should be part of the training modules, so they know about all this before you deploy them in the field. That way, they will be able to better control it and better work this out. So thank you very much.
Can I say something, Bonnie? Is that there is a question, what UJG mean? Is the University of Global Health Equity. And during we want equity in health education or health science education, like that's the only way to get equity in access to healthcare. But what we do, first lesson, we teach that to our students. It's in the rural north, the class is open inside the community. They see all this thing live. And we educate them through the bioscience, knowing that it's not genetic that is the problem. It's what I'm called the zip codic, because it's your zip code that is your problem. It's a zip codic disease. So we teach all this. We teach the principle of global health equity ownership. We teach history. We teach the history of Africa, the history of other countries, and we embed that in the history of the world after the Second World War, where big institutions have screwed up the future of Africa and other countries, and what to do to correct that, and to see that happening again, because the forces that are good are increasing, but the other one are resisting a lot.
So can our students come and be students at the University of Global Health Equity?
Absolutely. We have students that are coming for 1 year doing a master in global health equity, or internship, or 3 months of fellowship in Rwanda. Yes, we have students from Hong Kong, from Australia, from US, from Europe, many countries in Africa, of course, because we serve Africa first. But what we teach is those principles. I don't know, I ask all students, go and read where Rwanda come from and where we are. We have only $820 per capita. You have more than 55,000 per capita. And we have a better outcome with generic and HIV treatment. COVID, no death in the country the last 3 days. It's under control, even without vaccine. And we manage, because we create a resilient health system, people-centric, and using the traditional and the respect of the communities, make them part of the solution. They are not part of a problem, and health is not a commodity, it's a right. So I have to provide it. People can even sit. I need to keep them healthy as much as possible. But participation process, etc. We don't talk about those human rights that are that the high income countries are using to blame others when they don't respect that themselves, because many of those tools are tools for colonial power. So we teach all this to our students, but to do pacific change across the world, where they will go.
Everywhere. Call me.
Everywhere.
We have room for them at UMB. Call
Please.
us.
Please.
Call us. We have a scholarship program you may have just heard about. We get some collaboration, and thank you both. We are very reluctantly out of time. I would love to stay and talk more with both of you. And I've gotten several messages from colleagues, not students, saying, why are you saying students could go there? What about faculty? So
we have faculty for more than 17 US institutions have partnered with us who are coming for 3 weeks, etc. And we exchange, we learn from them, they learn from us. We have faculty from Asia. We are a global platform, and we fight for it because it's in Africa with an African spirit, but a global vision.
Love it. We have a lot of people wanting to come and learn.
Welcome.
Thank you. Thank you to both of our very distinguished guests. I am blown away and very appreciative of your contribution to this discussion, which in my view has been so critically important. Thank you, Dr. Binagwaho, Dr. Sow. I'm Bonnie Bissonette, and I will turn this over to, I believe, Dr. Carlos Ferran Guzman.